Public dialogue and civic engagement play an important role in improving the health and well-being of Texans across our great state. That's why Blue Cross and Blue Shield of Texas is a proud supporter of free Texas Tribune events like the conversation you're about to see.
So we're talking about access, and I promised we would get to Medicaid expansion, but first I want to start outside of there because I've been a healthcare reporter for the Texas Tribune for several sessions, and it just never seems to go anywhere. And so my question for the panel is, if anything could change, right? Who knows what the 2021 session is going to look like? But assuming it, oh, great, I'd love to hear about that. But assuming the makeup looks similar to how it did in 2019, and Medicaid expansion is off the table, what is the single biggest recommendation you could make to the state legislature as far as improving access goes? And Mr. Vela, we'll start with you.
Thank you. Please, Manny, if you don't mind, I'm
Sure.
more comfortable. Good morning, everyone. It's an honor to be here with the Tribune, the Texas Tribune, and it's an honor to be on the stage with my co-panelists. And a quick thank you to the Texas Tribune for all that y'all do. You and Evan Smith and the entire team are phenomenal. I thought about this a lot over the last couple of weeks when Evan called. And to some degree, I've always taken the position, certainly over the last 5 or 6 years, that if this is a semantic game based on politics, then let's call it something else, right? If we're not going to call it expansion of Medicaid, but we know the need exists, then let's call it something else. So my hope for this legislative session would be, let's concentrate, if we can, just on incremental gains, right? We have 11% of our children in the state of Texas currently uninsured. That's dismal. That's embarrassing.
And that number is going up.
It's going up as our population grows, and the adults are over 20%. And you're right. And by the way, 27% of uninsured folks happen to be Hispanic, right? And if you consider that we have the highest rates of uninsured in all of Texas, and Texas has the highest rates of uninsured for the country, that puts us first, right? I'm not bragging about that. That's just ugly. So this is where I was going with this. If we could ask the legislature to consider the incremental approach about how do we take care of the children in this state first, and then build towards expanding access across the board to adults. But like I said, I don't care what they call it, Senator. I don't really care what they decide to call it, right? The goal is access to care because we know that improves. Thank you so much, Doc. You got it. Thank you very much. That improves outcomes. Well, then let's go on down that road.
I hate to pour some cold water on that idea. I would just say maybe don't call it the Texas solution, because I do remember that one. Yep. I don't think it passed either. Ms. Marks, for you, the single biggest recommendation you could make if it's not Medicaid expansion, what is it?
If it's not Medicaid expansion, there were missed opportunities in the last session under the current law, including some of the administrative processes that are kicking kids off of Medicaid after 6 months when it doesn't have to be that way. There was the opportunity to expand coverage for pregnant women beyond 60 days so that it covered them for a year. And those are really small incremental changes that are not Medicaid expansion and that could make a significant difference, and we couldn't get those across the line last time. So they could at least start there.
Dr. Margo?
Again, there's no real easy solution, but we do know that primary care does save costs, increases access. So really having more primary care physicians out there really does seem to keep costs down while decreasing hospitalization and emergency utilization as well.
So, Senator Johnson, what is... I'm going to break the rule now. We can talk about Medicaid expansion. What?
I was all prepared to follow orders.
Okay. We can start with there.
And it's very difficult to not talk about it. I actually would like to just say how pleased I am to be back in the Valley. I think some of the best work that's being done in the healthcare field is coming out of this region, and none too soon, right? So what can we do other than Medicaid expansion? And we're not giving up on Medicaid expansion. We need to distinguish between health spending and health care spending, and I think that we're spending an insufficient amount on health spending. That can be health literacy, it can be nutrition programs in school, it can be making sure that people have air conditioning in their homes, that they're taking their medications, and there are pilot programs around the state, and it's time to scale up the little projects of good ideas around the state, around the nation, and try to implement them on a broader statewide level, that's going to free up dollars. It's going to free up spaces in emergency rooms, better care, update some regulations regarding emergency admissions and mental health. There's so much we can do outside of Medicaid to help people be well longer and get less sick, that is going to take some of the pressures off the cost of providing the actual health care that we want to do through Medicaid expansion.
Okay, let's talk about Medicaid expansion. What do we, or what is the, I want to return actually to an idea from the last panel, which is there's a Republican administration in the White House which is signaling that it is willing to do certain things to the Medicaid program that certainly the Obama administration before it wasn't, in terms of flexibility for states to impose things like work requirements so you don't get coverage, unless you have a job, et cetera. Maybe, exploring flexibility in terms of benefits, et cetera. Is there a point where Texas gets enough flexibility that it actually says, okay, fine, we'll insure some more people? I'm just, curious, taking the temperature of the next session. There will be potentially a different presidential administration, but it seems like if Trump's, still in the White House, you couldn't really, as a Republican leader in Texas, you couldn't really ask for more, at least in terms of the flexibility question. Just curious to take the temperature, and Senator Johnson, we can start with you.
Well, I think in a couple of days we're going to have some more details about what's being proposed. But we really have seen the administration put a stick in the spokes, not just of what Texas might do, but what the other 37 states in the nation have already done. In addition to the flexible block grants that are being floated out there, they have MFAR, which is essentially going to abolish the way the states have funded Medicaid expansion throughout the nation, and knocks out about 2/3 of the Medicaid dollars that we fund on a local level here in Texas. So that is a very big issue. I won't say catastrophic. Let's just say it's a big issue, because maybe they're going to come along with block grants that take care of all that. I'm not too sanguine that that's what's going to happen. I think that the block grants will have flexibility. I think there'll be check boxes of some things that are very good, that have worked in other states, but the money will be insufficient, because the objective of the program they're going to roll out is to cut $1.5 trillion off of the federal Medicaid budget. Well, how are we going to replace that? I think we're stuck with the same question in Texas. Are we going to make an investment as a state? Whether the federal match is not in fact a match, it's a block grant, or it is a match because Trump loses the election and the new administration says that's a bad idea, I don't know. And actually, I think that the introduction of whatever block grant program is about to come forth is going to contain some good components that we might try to incorporate into anything else. But there's no getting away from the question of, are we as a state willing to commit resources to health care? Whether you're a Republican or a Democrat, I think the ability for us to avoid that question has expired. Just like last session, the ability to avoid the education question had expired, and you saw bipartisan efforts to do something transformational. It is time for the exact same thing to happen in Texas on the healthcare subject.
Would you vote for a Medicaid expansion if it came with, significant sort of conservative concessions, say a work requirement or certain, waivers of benefits coverage, that sort of thing?
Yes and no. Yes, I would vote for something that's less than what I want. I think work requirements are a demonstrated failure, and they're tied up in the courts. So, ultimately, something is better than nothing. And I also think some of the conservative bells and whistles that have been tried out in other states are pretty good. So we got to cooperate. That's the nature of this game. But I'm hoping it's not just another little increment that we dress up and pretend that we've solved the problem when really we've just picked up another 150 people. I want something big.
Yep. So, Manny, you referenced the sort of branding question. I was curious if you had ideas going into 2021 about how to reframe the question of more coverage.
Two things. First, Senator, thank you so much for bringing up MFAR. I can use the word catastrophic because the reality is if the supplemental funding is taken away for hospitals like Valley Baptist, it could be catastrophic. That's what allows us to do the work we do. And just so everybody knows, our uncompensated cost for 2019 was $170 million. The only way that's defrayed is through our current supplemental programs, and MFAR is proposed to do away with those mechanisms. So thank you for bringing that up.
Is that mostly because of uninsured, or are we talking underinsured? How
It's
does
a
that break down?
combination, Edgar.
Yeah.
It's almost half and half, to be honest with you. But the supplemental funding that we're receiving, it's for services rendered previously, but it's based on the level of Medicaid care or work that we do and uncompensated care that we do. And so I'll go back to it could very well be catastrophic for not only Valley Baptist, but many hospitals around the state. The branding issue, and Senator, thanks, your comments are refreshing, to be honest with you. And I think you're right. I think our system has worked for so long because good, solid, pragmatic people such as yourself have been willing to compromise. And I guess I'll go back to the first question about what would you like to see in the branding around it. If I could see total expansion, that would be phenomenal. Look, I was telling Michelle Apodaca before we started here this morning that the reality is we have 6 years under the belt, 5 to 6 years with the Affordable Care Act. Fortunately, we have a track record. We don't have to project anything anymore. Right? We know now that we've left tens of billions of dollars on the table. Our dollars, our tax dollars, by the way. We know that, in fact, the uninsured population has continued to grow. We know that the costs have continued to grow, right? Which is a nice bridge to the senator's right. There are models out there. All but 14 states have expanded Medicaid. There are models out there that do work, right? The work mandate comes from Indiana, is one of those states, right? That's the vice president's state. And so it doesn't surprise me that he would throw that out there, but I don't think it's been successful, to the senator's point, right? So let's go and see what has worked around the country. And I'll go back to this. It's expansion of access, right? And if politically the leadership in Austin cannot handle the phrase Medicaid expansion, then I don't care. The goal is to address the lack of access to many people. And by the way, this isn't just lack of access, and it's a subcomponent. Lack of access for folks who don't have insurance coverage. There are people who live in rural Texas today that don't have access to care, and the doctor here could absolutely address that for us. He lives in a rural county, so.
Well, yeah, let's jump in on that point. Dr. Margot, I think when you're talking about problems in Texas with people accessing healthcare, you cannot, avoid talking about the challenges in rural areas. Certainly rural hospital closures have gotten a lot of attention, but from a provider standpoint, how dire is the situation right now? And, what is your message to the legislature? Like, what do you do about it, specifically the rural access question?
Realistically, we're at a tipping point, and we've really been there already for quite some time, and the hospitals have already been. You guys are all very good at trimming the fat, and all of our healthcare systems are already so lean. But in rural areas, a lot of times you really don't have the extra insurance to take care of the folks that really need the help, and or to share those costs at the hospital. So you're looking at we're one of the poorest counties in the state, and you've got a high unemployment rate for the most part. People who do work, mostly or seasonal or part-time work, and don't get healthcare coverage. So when we're talking about uninsured, we really mean uninsured. When I talk about Medicaid, Medicaid people are the ones that pay for everything. And even those things are so limited. One of my colleagues is actually here in the room that works with us over there. And, we just want to take care of patients. You show up, we're going to take care of you, especially in the emergency room. You come, Dr. Putty, to take care of you in the hospital. But there's so many limitations that are placed on us that we can't be the patient advocates that we want to be. And we try and, he's having a call almost every day just to get authorizations and try to get things done. And I even have personal experience that maybe I'll share a little bit later with my dad, who just went through this whole process. And after 4 months of basically becoming paralyzed from the waist down, is just starting to get up and walk around again, all of which could have avoided if he'd gotten the test he needed when he needed it.
And so that brings up the point that some of what we need to do is re-examine our regulatory and statutory framework here and update it to match the needs of the people and to match developments in the medical field. Legislators don't actually know that much about those topics, and so we rely on experts like these panelists and all of you to come to us and say, this is in the way, my dad needs help, and in fact, we had a couple of bills last session where we were able to streamline redundant federal and state procedures and things like that, and that, of course, is free, right? So that's a good place to start, but it's not a sufficient answer to the question.
Specifically, if, you brought up updating regulations. One thing that was, asked as a question last time was maybe updating some scope of practice rule changes, which is, perhaps one of the thorniest, most politically sensitive healthcare issues at the legislature. You get even as reporters, you write something about it, you tend to get an angry phone call. Senator Johnson, is that something that you would be willing, or that you're interested in looking at next session as far as
interested?
access? Yeah.
Yeah.
Where specifically do you see scope of practice changes?
It's going to come up every single session. Where would scope of practice changes help? I'm going to look to my medical professionals for advice on that question, and they're going to disagree with each other, and that's kind of my job to sift through all that. I do think there are ways that scope of practices can be tweaked to encourage more services to be available in underserved areas. I think we got to be very careful about it, because sometimes when you loosen up a scope of practice so that you get more care, what you wind up is more expensive care because it's not done right. At the same time, we don't want monopolies in places where we don't need them. I think that what worries me most about the scope of practice conversation when you're talking about rural health care is that we talk about it as if it's going to solve the problem. It may help the problem, but what we're going to need to really solve the problem is more efficient ways of delivering care, and that's where I think some technological advances are going to help. Home health is taking off. We need to think differently about the kinds of things we compensate for home health services and things like that, but healthcare starts to become an infrastructure issue. You may have a county where people don't have broadband access, so telemedicine isn't going to work unless we invest in some infrastructure as well.
Ms. Marks, I want to talk to you a little bit about access. Obviously, it seems like in the healthcare world, things don't change until the payers start paying for it. And you're in kind of a unique space where you kind of you can act as almost like the startup payer in certain circumstances. Where do you see change that needs to happen as far as what is not being paid for right now that, governments like Medicare, Medicaid, or private insurers should be paying for as a way of improving access generally? Like, where could the payers get the biggest bang for their buck?
By paying for health and not just health care. We are having the wrong conversation in this room, in the state, and in the country when we just talk about health care. There is no inherent value in health care except to the extent that it affects health status. The health status in the U.S. is going down. In this region, it's not very high, and we continue to spend more and more money on health care. We've conflated the ideas of health and health care, and we talk incessantly about health care, and we don't do enough to actually produce health. Our outcomes are not in line with the money that we're spending, and we need to change entirely the way we spend our money. And your mention about payers is exactly where it begins. People, hospitals, doctors, organizations do what they're paid to do. We pay the most amount of money to take care of the sickest people in the most complicated ways, and so that's how we've built an industry that specializes in that. We are not incenting any kind of investment in actual human lives so that they can be healthy in the first place. Sometimes we'll spend some money on preventive care. We're doing an increasingly better job on recognizing the value of preventive care and screenings and things like that. But we are completely ignoring, particularly in a region like this, the cause of diabetes is largely preventable, and it is preventable outside of the medical establishment. And we don't have those conversations because we just keep talking about the price of health care. What's offensive to me about the price of health care is not that we're spending almost 20% of GDP on it, it's that we're not getting value for it. Our life expectancy in this country is going down, and we are spending more and more. We're having the wrong conversations, and we're paying for the wrong things.
You mind, Edgar? Thank you. I completely agree. We should be talking upstream versus downstream. But I will throw this caveat out there, a little twist down here. There are groups down here trying to educate our general public from an educational perspective about lifestyle changes, right? And Judy Quisenberry's here with the Valley Baptist Legacy Foundation, and they support numerous efforts in that regard. So I'll throw that out there, that there are groups down here trying to address it from that perspective. The only other thing I would add is when we start talking about access to care, right, basic primary care, then you do become more preventative with the processes, right? And so therefore, that is more upstream than waiting till somebody is acutely ill with diabetes, which we have the highest rates of diabetes in the Rio Grande Valley, right? And so I think you can tie those conversations together, I should say, because the more access people to have to good quality primary care, the earlier diabetes might be caught, or if you're right there on the cusp, there are things that can be done, Dr. Margot can tell us, that can prevent diabetes, right? And it is lifestyle changes. I absolutely agree with that. However, I think those two can fit nicely together, education, primary care, for a healthier population down here in the Valley and beyond.
You know, Adam, one of the most interesting things about what the Trump administration may be doing is they might actually be opening up some possibilities to redirect some funds that were typically just completely earmarked for health care and funnel them more over to health. And that's a good thing. So whatever administration is in place next January, I hope that avenue is explored and pursued.
Yeah, I know North Carolina, the example of North Carolina is often raised as, hey, look, this Medicaid waiver was approved, so North Carolina can essentially, they have permission to kind of break the traditional rules of Medicaid and pay for some things that it doesn't traditionally pay for. I'll pose this question, to everybody. I think at the legislature there is often a hunger to make a change if it has been proven elsewhere. And are there other sort of examples that Texas could be following from around, other states that have, sort of creatively gotten at some of these access questions, in ways that you don't have to use the scary M word of, Medicaid expansion?
I think Indiana is a terrific model for Texas. They had a really cool acronym that we don't have, HIP, the Healthy Indiana Plan. So we'll have to work on an acronym. But the way they were able to expand, Ohio too. I mean, John Kasich had said Medicaid's a failed program, we're not doing it, and then he did it. The governor of Indiana, a guy named Mike Pence, had taken a similar approach. Why did they do it? How did they sell it? I mean, politically, it's as important as substantively what they did. They said, look, we already had this great Medicaid program. Costs got out of control, but we controlled the costs. And what we did is we told the federal government, we don't want normal Medicaid expansion. We want to just make our Healthy Indiana plan better. So if we can talk about it in terms of, look, we have a system in Texas that's serving the people it serves well. How can we partner with the federal government to expand the population that's eligible for that? I may have lost your question, so other people should talk about it. Models and stuff they do. Well, Indiana has health savings accounts. And you think that's just for rich people who can afford health savings accounts, but they set the monthly contributions ranging from $25 on down to $5. And then you alter your state laws so that people don't get in trouble if you, as a charity, help someone make their $5 contribution. And it's been shown through polling that the enrollees in the Indiana Medicaid program actually take some pride in putting their $5 in every month, and they're taking better care of themselves. So I think there are model states. I mean, look, every state in the country has done well with this. So we don't have to find just one. They're all doing pretty well. But if there's one model politically and in terms of what's working for their population, Indiana's a pretty good place to look.
But you'd have to be willing to have the conversation, and I'm so delighted that you are pressing on with this. I know that, I think it was your first session last time.
Yes.
And to see the enthusiasm and that you'll keep it up into next session will be great, because we've waited way too long to have the conversation. We waited for Obamacare to go away. It didn't go away. I'm not sure it's going to go away. The people who said they wanted it to go away now are not so sure they want it to go away. Trump is here, at least for now. It hasn't gone away. And if we don't have the conversation about taking advantage of the opportunity that is there, then shame on us. And I would challenge those who say Medicaid expansion is not the right way to go. Come up with another idea. Then you come up with something. This state, prior to Obamacare, didn't have a plan. It still doesn't have a plan. And so if we're not going to take something that's on the table, come up with another plan. But we can't do nothing.
But what I take away is there's something of a chicken and egg problem. I mean, we just spent an hour on the last panel talking about how costs are just out of control, and I think the conservative response in Texas has historically been, we can't afford, with costs what they are now, basically to expand access if what that means is expanding health insurance coverage. And so I wonder if the way to get at the access question, at least politically speaking, is to aggressively go after costs, and whether you see any sort of appetite for that, if there's a way to go about that.
I want to quote Ray Perryman. A lot of y'all know who Ray Perryman is. He's economic advisor for 6 governors, the state legislature for 10 decades as well. This is his quote, and I think it goes to what you want to talk about, Edgar. It says, forget all the other positive benefits you're having. Forget you're helping people's health. Forget all that. Just look at the numbers. And you look at them, you say, this is a no-brainer. We need to be doing this. It's really a political situation. It's just math, right? So for folks who make that argument, there's plenty of analysis has been done that, in fact, expanding Medicaid through the current program actually would help our economy here in the state of Texas. And this is, I love it when a moral and economic argument are joined at the hip. It doesn't always happen, but it is happening with this particular issue. It has happened for a long time. The moral part is we live in an incredible state, right? Economically, our folks brag about being not one of the top economies in this country, but around the world. That means we have the ability to help our fellow Texans, and we're not doing so. In my mind, that would be the moral argument. The economic argument is just the economic analysis that Perryman and many others have done in regards to the stimulus that would occur by expanding Medicaid in the state of Texas. And when to me, it's an incredibly forceful situation when you have both the moral and economic arguments that you can stand on. And I think just looking at the history of the other states that have expanded and looking at where we are today with the population, the need is even stronger than it was when the Affordable Care Act was passed in regards to access. And before I forget, let me throw this in there, because we can talk about expansion of Medicaid all day long, but we better combine that discussion with, if you expand Medicaid, you've got to make sure that your Medicaid primary care network is solid, right? Because if it is not, it defeats the purpose.
Yeah, again, not just having access is important, but being able to pay for the preventative care, like you guys have already bring it up. I mean, that really helps avoid a lot of these situations down the line. But having that primary care base is crucial to having that, and allowing them to do the preventative care that they're trained to do. That's really a crux of this as well.
And Elena's points about paying attention to health and not just health care has a cost component as well. One of the ways you reduce costs is by avoiding costs, which is by making people healthier.
Yeah.
And as to the numbers, and Ray Perryman is, as I think, one of the most important voices on this subject, he will tell you that for every dollar we invest, we're going to get a $3.31 return over 10 years. But I said, but I live in Texas. We don't look on 2-year time frames. We're lucky if we get past a calendar quarter, but at most a biennium. And he says about a third of that investment return comes within 2-3 years. So in a single biennium, or at most 2 bienniums, we're actually going to turn a profit from money that we invest. I know that sounds counterintuitive, and part of this is just going to be educating legislators. We really can afford this. In fact, it's a budget. Every state in the nation has either seen a budget neutrality or a budget plus. Now, there are states that have had moments when things got out of alignment, and then guess what? You fix it. But for the most part, expansion of access, Medicaid expansion, whatever you want to call it, is not really a financial question. At least there's not a financial reason not to do it. There are financial reasons to do it.
I'd like to shift gears a little bit here and talk about something that has had more movement on it at the legislature in recent years, which is the topic of mental health and funding for mental health care. Again, I think any discussion about access would be remiss, maybe I used that word incorrectly, but you can't not talk about lack of access to mental health care, in the access, in the debate over access. Dr. Margot, I was wondering, from the provider perspective, where do you see the biggest needs in the mental health care space? You work a lot in emergency medicine. Are you seeing a lot of these, mental health needs presenting in the emergency room? Are there more efficient ways to deal with it? I'm just curious to hear your thoughts as a provider.
So quite literally every day, I have at least 1 or 2 patients being brought in for screening. I have 10 beds in my ER. One of them is tied up for anywhere from 2 to 3 to sometimes 2 to 3 hours to 2 to 3 days waiting for a patient. Either the screening usually happens pretty quickly, but then trying to get a place for them. And most of these patients, this isn't the first time they've come in. They're coming in because they don't have access. They can't get in to get their meds. They can't pay for their meds. Some of them, again, because of their conditions, feel better when they're on their meds, so they stop taking them because they feel fine. And so you run into this. It's a lack of education. It's a lack of having the right resources available to keep these folks healthier. And really, you're tying up law enforcement resources because most of them are under a section of protective custody. So now you have 1 to 2 police officers in the ER. I mean, we feel very safe, but having the extra law enforcement around. But that's, the community's losing out. And then you look at the resources in transporting these folks. When a lot of that, if we had a little bit better resources locally, I mean, the border region is we only have a psychiatrist in the county. Yeah. We're not the only county that doesn't have psychiatrists. Right. And one psychiatrist isn't going to do it either.
Yeah. I want to be sensitive here, but I'm just curious if you can sort of in broad brushstrokes kind of paint, a profile of who we're talking about. Are these folks who are, do they have health insurance? Are they needing specialty, a specialized level of care that is just not available to them here? What are kind of the, biggest challenges specifically when we're talking about this population?
We're looking at age group. We're looking at anywhere from kids in high school, middle school. You've got 20, 30-year-olds is probably the majority of them. They're young and healthy enough. Unfortunately, a lot of these folks, as they get old enough, they don't survive. They'll develop chronic medical conditions. Sometimes the meds themselves will cause some additional symptoms. But again, they're better than where they're at without taking any med at all. And so we do have a few older folks. Some is dementia, but a lot of it is these various psychiatric diseases. Again, there's no place to get their meds. They don't have the physicians to prescribe the meds sometimes. Fortunately, again, using technology, we do have telemedicine, and we are using psychiatry that helps these folks a lot. And a lot of it is just pulling the resources of the community together. And so we've been working real hard to do that. but it all gets back to funding. And we had, I think, some additional access for 2 to 3 months, and then the money ran out. And so now we're back to our patients who have no funding. A lot of them, some have funding, but a lot of them don't have any funding of any kind. So they have no insurance, and they're just on the streets, quite literally, dodging cars. And so police are picking them up, putting them under order of protective custody, and bringing them in, and they sit there for hours waiting to try to get transported somewhere. You know, most of them end up in San Antonio, Austin. They get treated for a week or two. They get at least slightly stabilized. Then they're back in our yard about a month later, or sometimes the day after they leave.
Yeah.
If I may just add to that, look, I think we all recognize mental illness is indiscriminate, right? Doesn't matter if you're rich, you're poor, doesn't matter what ethnicity you are, does not matter, right? And so from that perspective, Edgar, it's really hard to put some kind of a stereotypical type of characteristic on somebody who has mental health. But Dr. Margot is also right, and we face this in our 2 hospitals through the emergency room. The reality is we need patients where they can best be treated as quickly as we can get them there. And we do have issues right now in regards to mandates and regarding transportation to those type facilities and getting folks to those places. The reality is an individual who's in our emergency rooms like yours, that's taking a room up. It's definitely a risk, and most importantly, that's not where they need to be seen to be treated the best, right? So, and I do think it is access, but it does float back to a lot of these folks don't have insurance, so therefore upstream, Elena, there's no conversations taking place, and by the time they get to us, they are acutely ill, but on the mental health side.
And so there may be some things we can do on the legislative side as well to make it possible for services, mental health services, or teams of mental health or law enforcement and mental health and medical health professionals to visit on site and maybe triage the patient outside of an emergency room setting. But all this stuff is tied up in a regulatory and statutory framework that sometimes can get in the way. So we want to loosen up things like that. One other statistic, I know we're not exactly talking about Medicaid expansion right now, but
when are we not?
When are we not? Nationwide, approximately a third of the people who are picked up in the expansion gap are receiving mental health services.
1/3.
And there's a real opportunity in moving all of that upstream. What you're seeing in your hospitals and the emergency room is the product of not having that institutionalized. And we see an increasing effort in primary care, and particularly in the federally qualified health centers. And you've got Katie Caldwell here from Legacy in Houston, who does an amazing job of integrating behavioral health into primary care and takes care of people so that they don't escalate. And we don't have enough of that investment. I'm delighted that the legislature has put more attention and more money over the last few sessions into mental health, but a lot of that is not directed toward sort of the garden variety mental health conditions that really can be treated in an integrated primary care setting. So I'd like to see more of that.
I want to stay kind of in this area, but more broadly, you know, we talk about going upstream in the health intervention world. We got at this a little bit in the last panel, but I guess my question is, how far upstream should the state go, right? Because you know, you've brought up there's issues with transportation, right? Like, is it logical to say we need healthcare funding in the transportation budget? Like housing, certainly. There's, you know, a lot of folks say if we could get, you know, chronically homeless folks housed, their healthcare costs might drop. But that costs money, and then you have to, you know, find the budget to do it. I guess I'm just curious. And Elena, we can start with you. Sorry. How do you make the case that, you know, other parts of the budget should grow, you know, from a healthcare lens? Because it's kind of a big ask in a state where there's a lot of, you know, restrictions on the amount of revenue that can be raised. You know, the budget can't grow that much each session.
So I'm going to, I guess, say 2 things that will sound inconsistent, but I don't think they are. One is that if we really want our health care budget to produce better health outcomes, then we would look at the factors that determine what the health outcomes are, and we would have the dollars follow those factors. Secondarily, people don't exist in a vacuum. They have needs that span health and education and transportation and housing and environment. And there are multiple opportunities for braiding the funding streams. And the legislature can do that, and the federal government can do that, where you look holistically at what it is that people need, and you don't silo every single funding stream so that you have to go here for the housing and here for the health, and you spend so much money chasing down the opportunities that are there because we've looked at it separately. And I'm not an education expert, but from what I understand from those who work in the education space, a lot of the problems that struggling students have are originating in their lives outside of the school. And so the very best school with the best facilities, best teachers, best curriculum can't make progress when a student comes from a place of interpersonal violence or hunger or sickness or anything else. And if we keep on looking at all of this stuff in silos, then we're not going to get there because we don't want to pay for what someone else is doing. There are new economic models that are being developed, and we are trying some of them out through small experiments that the Episcopal Health Foundation is funding to look at how you work cross-sectorally to allocate costs and benefits where no one institution or sector pays all of the costs, but it also doesn't reap all of the benefits. And it's really hard to do, and it's much more complicated than saying, well, I only do housing, and so I can give you a house, but I can't do anything about the wraparound services you need. But you've got to consider, and I would ask the legislature to consider people and the value of people and what it is they need to live a healthy life, and look at it from that perspective and make those kinds of investments. And that benefits the state and the state's economy in the long run without going, well, we can't spend any more. I don't want to hear again Medicaid is crowding out other state spending. Ask why that is.
Edward, do you mind? I'll take a little bit different approach on this. I think you're absolutely right on all those points. I'm not a big believer in let's throw money at a problem and it's going to dissolve. It typically doesn't work that way. But the way I've been looking at this with my institutions, the hospitals in Harlingen and Brownsville, is proactively working with school districts around our areas. Because if you think about it, the school children will go home to their parents, right, or whoever they live with. So you have an instant funnel from an educational perspective of material, of a change of mindset that we can start with kids at the elementary school level, even junior high or high school. But we have a conduit to pass that information on to their folks. It's a little non-traditional to some degree, right? Because we're not looking at the legislature to try to help us address this issue. But noting that we probably shouldn't wait or can't wait all the time for the legislature to make these kind of moves, I think we can all be more proactive in that regard, especially if you're involved in healthcare. We have information available to us on the wellness side. And if you can work with your school districts in regards to passing that on, then you can have an impact. Definitely for and with children at a young age. Look, I was born at my hospital in Harlingen. My family's lived in the valley for 150 plus years. I love barbacoa. I love menudo. I love those things, right? But the reality is I've changed my lifestyle over the last 6 months or so because I know from a wellness perspective that's not where I need to be. But it is a change in lifestyle. But it's got to start somewhere, right?
Yes, and educating people only goes so far. People have to have the ability and the means to be able to access healthy food, to exercise. If you're working 3 jobs and taking care of kids, you're barely making ends meet. Right. If you're living in a colonia, you may not have sewage and running water. And so you have really basic conditions that thwart the opportunity that people have when they get the education. And so we've got to do more than just tell people it's your fault that you're not eating right and exercising. We have to have the conditions in the state that allow people to have a healthy life.
I completely agree, Elena. You're absolutely right. And I wanted to reference that, so I'm glad you did, because if you look at the staples of the food down here, the rice, the beans, the tortillas, right? Sometimes that's what people can afford. But so you're absolutely right. I don't disagree with you at all.
I'm gonna
I like
interrupt-
beans. I like beans a lot.
I'm going to interrupt
find
just,
our
just
pinto?
for a second, and I'll let you jump back in. It'll shortly be time for an audience Q&A portion. We got about 15 minutes, so if you want to start lining up at the microphones, go ahead. But Senator Johnson.
Well, picking up on what my two co-panelists have just been talking about, we tend to think that people make decisions about their health, but the fact is very few of us make decisions every day. We act out of habit. And by educating people in their youth, you start setting in place good habits, which is going to make for better health down the road. But the other thing that Elena's talking about is your environment. It's difficult to make good decisions about buying a head of lettuce if there's no lettuce within 7 miles and you have to take a bus to get there. So you've got to create an environment, not just where people can make good decisions, but where they're likely to. And that's going to take some work from legislators, and it's going to take a lot of work from health professionals who have vision as well. Hopefully, between the two of us, we can get it done.
Yeah, we'll go ahead and open it up to audience questions. Again, feel free to line up at the mic. Just please introduce yourself, and again, make sure that your question is a question. Thank you.
Good morning. I am Danielle. I am from El Milagro Clinic, a community nonprofit community clinic that picks up the underinsured, the non-insured, and illegal immigrants in this region. My question is for Mr. Margot. Do you participate in free rural clinics or community pop-up clinics in your area or in the RGV?
We do what we can. Again, working the 12-hour shifts that aren't really 12-hour shifts, you go to 13, 14 hours usually. We do, again, in the ER, we take everybody who shows up. And so unfortunately, we do see a lot of people that even if they have a primary care doctor, they can't get in to see him. There's a long line. Sometimes, unfortunately, they may be even being treated for the right thing, but because there wasn't time to educate them as to what the symptoms were going to be and how long it was going to take, the antibiotics are not going to work tomorrow, and you're not going to be well the next day, they show up in the ER. And so then they get tied up and sometimes end up leaving without getting seen, which then makes us look bad or as if we're not doing our job, even though they probably didn't need to be there to begin with. And if we're tied up taking care of people, I mean, literally dying or having heart attacks or having strokes, that we get one of those that shuts us down. And, we do the best we can what we have, but again, a lot of it's resources, a lot of it is it having that extra education, a little bit extra time to talk about preventative care, talk about, walking a few steps extra every day. So we do, again, we help when we can, but a lot of the stuff that comes into the ER even is stuff that probably doesn't need to be there, that can easily be handled by a primary care doctor.
Richard Atkinson, Family Network in Houston, Texas. The comment was made about avoiding the question, and the block grants or other fundings that we have in place right now are going to be substituted. The talk is going on that it's going to be replaced with a program that will look at actual numbers served. So our failure to expand Medicaid or Medicaid expansion, we lose the opportunity to include more people being covered. So when the alternative funding source or program comes into place, we're going to lose out even more monies. Mm-hmm. And I want to know what is the plan to address that shortfall, because we know it's coming, just like we know we lost out billions, which translates into lost opportunities for facilities, physicians, economic boom that we could have had here in the Valley.
Right.
So I would like to know what the alternative is to, I guess, make up for that shortfall.
I hope that's not right. I share your alarm that if they're going to base these block grants on what you've been doing for the past 3 years, the fact that we failed to expand Medicaid means we have cooked our own goose, which is a really bad thing. I have heard rumors that the block grants may include an expansion component. So until we really see it, I don't want to stay up at night worrying about it. If in fact we're cooked, I don't know what we're going to do, but I think we're going to have a very, very hard conversation in the legislature. I hope you all will be there about making state investments, because our mechanisms are also getting taken out from under us. So that's going to be a really hard question. I wish I had a quick answer for you, but even if I did, I still have to convince everyone else.
Right,
so.
correct. With all due respect, we know it's on the horizon. It's coming. Something's coming.
Yes.
and staying up at night not staying up overnight to address that issue kind of negates the fact that we should be up at night worrying about not doing it now, because there's too many people that could be served with the billions of dollars that we passed up already. And so whether we're looking at the future, I think we really, really need to concentrate what's going on now and the lost opportunity that we've caused for ourselves.
You're right,
thank
and
you.
we all agree.
Next question.
Hi, my name is Kyle Hayungs. I'm the founder of MRG Health. We're a virtual care management and biometric sensor company. So we do telehealth and remote patient monitoring, chronic care management. I meet with CEOs of hospital systems and elected officials on the daily, introducing our technology and what we're doing to leverage technology to basically solve a lot of these problems you guys are talking about. I've done speaking engagements on behalf of the Texas Hospital Association and just talking about new legislation and these new codes and how we need to adopt the technology. But I've learned that when I ask these people like how they keep up with it, they're kind of, I don't want to say caught in the weeds, but they're stuck on in the daily grind. What do your guys' organizations, or how do you guys keep up to speed on this, and how do you maybe fast track through pilot and IT security processes, because sometimes it'll take 5-6 months to be able to leverage what we're doing and get proof that it works. We do pilots, very short-term pilots that have so much data. So how do you guys adopt those things and vet those things?
A question, I think, for the providers. If you guys want to take a step.
Thank you very much for the question. And Tenet, we are with Tenet, and so I only have experience with this particular company, and I can tell you Tenet's absolutely adamant about making sure we are taking advantage of the technology that currently exists. The review and approval process for these larger companies can be maddening. It can be frustrating. However, they have to make sure they're crossing their T's and dotting their I's. So be patient with us in that regard, but I can promise you that we understand the value of telemedicine moving forward. We currently use it in my hospital in Harlingen for stroke care, in our NICU environment for psychiatry. So we fully understand and are taking advantage of what's available. So I would just ask you, and it's not putting the onus on you, but it's an ask, just keep educating us. Keep educating the companies that provide health care on the inpatient and outpatient side, because I promise you, as we're talking about access in rural areas, et cetera, this is going to be a big part of that conversation. So congratulations on all the success you've already had. Don't give up. Just keep promoting, all right?
Yep.
Keep
Thank you.
educating.
Thank you.
Did you have any? Okay, one more question over here.
I'm stunned to find no one is in line, so I decided to step up. I'm Ann Dunkelberg with Center for Public Policy Priorities in Austin, and I figured what I could get away with at this point, since Evan wouldn't let me bring a PowerPoint, is to do some of those back mic kind of questions, like, can you not hear me?
Maybe a little closer.
Okay,
Thank you.
as they say, it's a little high. So basically, in response to some of the discussion I heard, I was flipping through my statistics, and so I guess I wanted to ask Senator Johnson, would you be surprised to learn that 85% of the Texans who are uninsured are actually in a working household?
No.
And I also looked at the smaller subset of uninsured Texans who would be picked up by Medicaid expansion, which would only go to 138% of poverty for adults, and that's 75% working households. The other thing I wanted to mention is if I look at a map of where the remaining uninsured are in Texas, there is a blazing stripe all along the Texas-Mexico border, all the way from El Paso, to Brownsville, and I think it's really, and 60% or more of our uninsured are Hispanic Texans. I think it's time for us to start acknowledging the discriminatory effect that our decision not to do the Medicaid expansion has on Texans of color. Even though Medicaid expansion is projected to pick up 1.5 million of our 5 million uninsured, we have a lot more to do besides just that, but it is such a low-hanging fruit.
Right, and I would like to piggyback off of that and ask a question, Senator Johnson, of you. Can you offer us a little window into kind of the political sausage-making process? I mean, do those discussions happen? I guess by that, I mean, do you think the other 30 members of the Senate are aware of the sort of geographic and racial disparities when we're talking about the access to coverage.
There's certainly a
disparities.
general awareness. The specific level of knowledge of each of the members of the legislature is probably lower than what it should be, because frankly, everyone's been afraid to talk about this issue. But the statistics that Ann Lassen just brought up to us are exactly the kind of things that Manny's talking about when we need to. How do we talk about this? 85% are from working households. I don't think all the members of the legislature know that. I didn't know that number, but it doesn't surprise me. And I look at this stuff all the time. So do these conversations take place? Yes, they absolutely take place, and they generally take place quietly. We need to move to an environment where legislators feel like they can talk about this. And a lot of that falls on the public really getting engaged on this. There was I forget which national publication just said that Texans are among the least likely people to vote based on health care. That's got to change right away.
When you say these discussions happen quietly, I just wanted to probe a little bit. Does that mean that
Names?
are there Republicans asking?
I think the Republicans are deeply concerned about the problem of access to coverage. I think they are terrified about losing not just losing re-election, but losing their influence. And influence is important to legislators for good reason. But there were attempts in 2014. There were consequences for people who supported it, and they're looking back and thinking, "Oh no, I don't want to do that." I just think it's time for everybody to wake up and realize it's not 2014 anymore. It's not the same environment. I think they would very much like to find a way to, consistent with their prior statements, consistent with principles of conservative leadership and Texas traditions and all of that stuff, which has served well in many instances, be able to say it is time to expand Medicaid.
I think we've got one more question, and you'll be our last. Thank you.
I was Salomon Torres with Unidos contra la Diabetes, which is United Against Diabetes. This issue of terminology is really critical, Senator, because you may not have enough votes this next session, but over time it's important to frame the framework for the next session. And I'll give you this example. CPRIT gets universal support, and it has to do with cancer research, not cancer treatment, not cancer care, but mostly research. There's prejudices that are attached to certain chronic conditions like diabetes, stroke, heart disease that are different than what's attached to cancer, which is more universally supported as far as a condition to work on. So I offer you this because from the ground, meaning from the field here where we're dealing with diabetes prevention, we don't deal with those high-level discussions that you have to deal with the opposite party. It's critical that different terminology get considered so that when you do discuss compromises, they find some middle ground that they could find acceptable to finally invest in these other chronic conditions the way CPRIT has over several $1 billion, as you know.
Thank you.
Great. Well, folks, we're about out of time, but I'd ask that you give these panelists a round of applause, and thank you for your attention.